You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Aaron Neinstein, Chief Medical Officer at Notable. We discussed designing systems that empower patients, the importance of understanding user workflows, and the power of invisible design in healthcare technology. We also talked about how AI can significantly reduce the administrative burden on healthcare providers, enabling them to focus more on patient care. Let's plug in. Aaron Neinstein, welcome to the pod. How are you today?
I'm great. Thanks, Craig. Good to see you.
And where do we find you today?
I'm in San Mateo, California, just 20 minutes south of San Francisco.
And it looks like you are at Notable HQ, or you've put up a sign behind you that implies you're at Notable HQ.
No, I'm here. We actually, most of the company is at headquarters in person together.
And that's on the 101st floor? Is that somewhere around? Do I have that?
That's right.
Quite the view. All right. Well, let's get a little kind of understanding of where you're coming from. I know that you're an internal medicine doctor who specializes in endocrinology. You still are seeing patients to this day, but you've kind of been around the sphere of healthcare related industries. Can you give us a little bit of an introduction of where you've been and how you got there?
Yeah. So as you mentioned, I was trained as an endocrinologist, but most endocrinologists really love biochemistry and the deep science work. And I was an American Studies major actually in college. So I was always somebody who cared more about Harvard Business Review or health affairs than I did nature or science. And so always very interdisciplinary, always very focused on sort of the people side, the human side of healthcare and care delivery. And so as I was coming out of my residency training at UCSF, had a hallway conversation one night, actually on Christmas Eve, the two Jews on call on Christmas Eve with our chief medical officer, and told her about my interests. And she said, well, we actually just signed a contract with a company called Epic, and we need physician leadership for the rollout. Are you interested? And I said, that sounds great. Of course, this is, 2010 in San Francisco, tech boom. All my friends are in tech, and with my interests sounded like a really interesting thing to do. So my last month of residency, I'm on an airplane to Verona, got Epic certified and helped, lead the Epic implementation at UCSF over the ensuing several years, fell in love with informatics. And then I went back and did my endocrine fellowship. During that time, again, being in San Francisco, the digital health boom had started, got very frustrated with how complex it was to download and use data from insulin pumps and continuous glucose monitors. And so found a group of like-minded people and co-founded a nonprofit company called Tidepool that builds software for people with diabetes and sort of integrating all of the device data and making it usable. And then as I came out of fellowship, UCSF decided to start its digital health program, or Center for Digital Health Innovation. And so spent the ensuing really about 10 years at UCSF building out the digital health programs. And that was all around patient access, referrals, self-scheduling, precision digital marketing, virtual care, telehealth, remote patient monitoring. And then in doing that, I had the opportunity to work with a lot of different vendors that we worked with at UCSF, some great partners, and realized that there was one really tremendous opportunity to integrate different systems together to create a more cohesive experience, and two, that we started using ChatGPT about a year and a half ago, realized that the world was going to change, and so decided to join Notable as chief medical officer about a year and a half ago, seeing sort of the confluence of those events.
So you kind of just pop back and forth between clinical practice, full time, it sounds like, and and the working on digital health type stuff, from the electronic health record to kind of the connection between hardware and software with continuous glucose monitoring, and kind of you like to bounce, I guess is what I'm trying to say.
So I was never full-time practice. I've always been mostly full-time in informatics and health IT, part-time practice. I think the common themes for me have always been, how do we help empower patients with access to their healthcare data? How do we make workflows easier for providers and patients? And in particular, I think one of the things that's always troubled me is so much of healthcare seems to put physicians and patients in opposition with each other. In-basket is a great example of this. For patients, in-basket messages are great, right? Like more access to my doctor, more access to information. But for doctors, it's not so great. Documentation after a visit, that's great. For a patient, here's more information about what the doctor's thinking about my care. For doctors, it's pajama time. And so much of care delivery, I think, has put doctors and patients in opposition. And to me, this is fundamentally broken and flawed, because I think at their core, the interest of the patient, and why did we all go to medical school? To help patients. Why are we here? To help patients. We're here to help them access care, get care, understand their care. And so I think it's our job as informaticists to design systems that actually support patients and providers being together on the same team against whatever health problems the patient may have, and towards improving the patient's health. And so it's really our job to design the systems, the processes, the workflows, the tools that make it easy for providers to help patients, that make it easy for patients to help themselves, and put them on the same team where we should be.
Yeah, I love it. And you said my favorite word, design. My co-author, Jerome Pagani, described exactly what you're talking about, with the idea of a brick wall. And hey, we want to make things easier for the patient. So one of the little bricks is out. You push that in. You're like, hey, it's nice and smooth for the patient. Well, unfortunately, on the other side of that brick wall is the physician or a clinician, right?
That's a great metaphor.
We want to make it easy for the docs. You push that thing in.
Now it's on the other side,
right? We need a bigger wall so that the things aren't poking out like that. Yeah. So let me talk a little bit about your time at the UCSF Center for Digital Health Innovation that sounds like you helped start. What were some of the projects that you focused on there, and how do you develop that? That wasn't there. So first you have to kind of create the infrastructure, and then you have to deal with problems. How did you decide what were the problems that could be either solved or mitigated at least?
Yeah. So, this was really interesting, because when we started the center, it actually was started on the academic side of UCSF. And so in the early years, the focus was on industry partners and projects that they would bring to us as areas of interest. But what happened about 5 years in, so we're talking like 2018, 2019, is our own care delivery system started to see opportunities to leverage the skills, the capabilities that we had built. So during those years we were working on the industry side, we built expertise in design. So we had, designers on staff at UCSF. We built expertise in product management. We built expertise in data science and AI development. And the health system started to realize that those were skills and disciplines that were useful to help solve some of the problems in the health system. And so from about 2018, 2019 on, we started applying those skills and resources into the health system. And so we were actually connected to the health system's 5-year strategic plan. So when the health system was focused on growing certain specialty service lines, orthopedics, neurosurgery, specialty surgeries, et cetera, we were focused on how to make it easier for the health system to do those things. As we were spinning up telehealth and remote patient monitoring as an increased part of our strategy, we focused there. So the really wonderful thing is we got to a place where we weren't, running around looking for things to do. It really was connected to the health system strategy and the strategic plan. And that's always a good place to be, which is, start with the biggest, thorniest problems and work on those. And so, over the course of those years, the main focus areas really were on patients seeking care. So we think of that as patient access, all the way from referral to person seeing their specialist and making that whole process as seamless and streamlined as possible. And then patients receiving care, which is, what is outside of the visit, what are all of the different touch points and areas that we can help make the patient's experience better and easier and their care process better.
Okay. All right. Well, that all makes sense. And you've succeeded when people are coming to you and you don't need to go looking for projects. When we were prepping for this call, or this podcast episode, I'd asked you for some things that maybe didn't go as well as you thought. Where you would. I don't know if I used the F word for failure, but things that didn't work. I think we all learn a lot from projects, and you would come up with several. And so I want to talk about right now, Aaron, all of your failures. Let me bring your mother in. We have her on the line, waiting on the line. No, no, we're not going to do that.
Thank you, Dr. Freud.
Yeah, we're not. No, lay down and let's talk about your mother and other kinds of things like that. No, let's talk about Epic Smart Sets. Epic Smart Sets. Now, I've had the similar experience as an Epic employee in the past, but so you had said that you were volunteered maybe to be on the Epic team for the UCSF implementation, and went to Verona and got some training, and then you built a bunch of outpatient order sets, or maybe those were inpatient order sets. Tell us that story.
Yeah. So, and many others probably had a similar experience. This, circa 2010 Epic, I was the front lines of our build, our deployment, which started in primary care and then outpatient medical specialties. And I went to Verona, I got my training, and then I got my to-do list from Epic, which said, go meet with every specialty and build and validate, 10, I don't remember the number, but call it 10 smart sets per specialty. And being a diligent type A endocrinologist, I did my homework. So I went out and I met with every specialty, and I spent dozens of hours building, validating, editing, tweaking. And then we went live and found out nobody used the things. And it was a powerful lesson that you have to understand what problem you're trying to solve. You have to understand your users' workflows and make sure that what you're doing, what you're building, what you're creating is actually solving someone's problem. And we hadn't gone live yet. And so we didn't know what we were doing, and we were just sort of following instructions. I know, one of the other things you and I have talked about in the past, which is a perfect contrast to this, was about a year into the Epic implementation, we got pinged by radiology that there was a very high frequency of erroneous orders for the wrong CT abdomen pelvis protocol. We dug into it and we realized that when you typed in CT abdomen into the Epic order search bar, the first one that came up was the wrong order. Can't remember what protocol it was, but it was not the one that was most commonly desired and used. And what we did is we actually just added a space bar. We added a space in between CT abdomen, and that allowed us to move the most frequently desired order to the top of the list. And sure enough, just adding a space, we flipped completely the accuracy of orders that radiology was seeing. So contrast those two things, right? One wasn't really sure what problem I was solving, just sort of like following a playbook, spent hundreds of hours building all these things that nobody used and ended up in sort of the waste bin. On the other side, we actually spent more time understanding the problem and sort of diagnosing what the user workflow was and where things were going wrong. And then the fix was literally a space bar. changing the order, and that transformed care, much more than all of those smart sets ever did.
Yeah, that's that. And you published that, and it's one of my favorite articles because it shows the power of design, right? It was CT abdomen versus CT abdomen and pelvis. And oftentimes people were ordering CT abdomen and they got the study that they ordered, but they didn't get the answer to the clinical question. And most of the time they really needed the abdomen and the pelvis. And by adding that extra space, they popped the pelvis up to the top of the screen, and the one that most of the time you didn't want ordered was only a quarter of an inch below. There was like one order between, so it was certainly right there. But people just go to the top. They just go to the top, and it's the first thing they see, and that's what they order. And so you followed the rule of making it easy to do the right thing, and I think that's amazing. With the first issue, it commonly happens. It's probably happening today when someone's implementing some new software or a new electronic health record, where, well, we need these things because that's how we do it today, and it's impossible for us to conceive of how we're going to do it tomorrow. Even if you show me screenshots or let me kind of play around in it, it's complicated. I had a similar story when I worked at Epic. I was working with a big children's hospital, and they were building, as you did, many order sets. And I had said, like, hey, this is a lot of work, and I suspect you're not going to use all of these order sets, and it's going to be wasted time, and maybe don't do it. And I got pushback, like, no, we're doing it. This is what they asked for, the doctors. And this is a physician telling me this. This is what my colleagues asked for. This is what I'm giving them. I'm like, okay. And then we went live, and sure enough, the same thing happened that happened to you, which is just the adoption was very low of most of the order sets. People just didn't find them helpful, and so they didn't use them. And we actually saw that on a post-live trip. I was walking with this. He was essentially the CMIO. I don't think we called them back then CMIOs, but that's what he was. And he said, "Hey, this is the guy that asked me for all those order sets. Are you using them?" And the guy goes, "What are you talking about?" He goes, "Oh, the order sets that you and I spent time creating. Remember, we went to the coffee place and we sat down and He's like, "Oh yeah. No, I don't use any of those. I remember that, but no, I don't. Those are dumb." And after he walked away, I said to my friend, the CMIO, like, "Hey, so I guess I was right. Yeah, like you shouldn't have ordered those, shouldn't have created those things." And he goes, "Oh no, I would do the same thing tomorrow if the." And I said, "Explain that to me," and because you don't understand our culture. Our culture among at least the clinical staff at that organization was, if you ask for it and if I give it to you, you're done. You can't complain, even if it doesn't work out. And he said it was worth it to get these people off of his back.
Wow.
And right. And so that's, I wouldn't have guessed that. But so sometimes doing the extra work is supportable if there are other benefits that you're going to get. And again, for him, it was, well, now they don't get to complain about the electronic health record as much as they would have. And that certainly wouldn't work at a lot of other healthcare systems, but that was the deal there. And, he knew the organization better than me for sure. So that worked. And I love the fact that UCSF is publishing some of these things. That article, you also talked about Dilantin ordering, and made a little change. Apparently, physicians were ordering a free Dilantin level. And just for our non-clinical listeners, Dilantin's an anti-seizure medicine, and it's got a narrow therapeutic margin so that if the dose is too high, it's toxic. If it's too low, it's ineffective. It has to be in just the sweet spot for someone. And so you measure to see what the level is in the patient's bloodstream. And you could do a free or total. And the free costs a lot of money, and it gets sent out, and it's fancy and difficult to run, and the results come back in like 3 to 4 days. And the total is much more kind of quick and dirty and gives most people what they want, what they need most of the time. And people are ordering the free, not thinking about the result, and then being upset when it didn't come back the same day. There were other things that you've done that you designed in the EHR to make it more complicated. You added friction so that doctors couldn't easily order the wrong test. I say wrong in air quotes. And those are the kinds of things that really are the unsung heroes of human-centered design in the electronic health record, right? No one's like, oh my God, this is great. No one sees the benefit of it except for the physicians benefiting, but not knowing that they're benefiting, right?
And if done well, these things can be really invisible. The common thing people reach for is, oh, let's build in an alert, to tell providers, are you sure? Like, what was the other option? What was the other thing we could have done there? Well, we could have popped up an alert saying, you sure you want to order a free Dilantin? Those are really expensive. And you know what would have happened? People would have blown through the alert and said, yes, that's what I want to order, because they would have wanted to swat the nuisance out of it would have gotten in their way of their workflow. So you have to actually look at people's workflow and design to it. Another example of this, actually a notable, we do, we help with HCC risk adjustment coding, right? So we suspect codes to help people get more accurate coding with risk adjustment. And I was, a lot of these products, they take providers out into a separate website or a separate panel to go work in, and they say, oh, ours is so easy. The user experience is so great. Providers are going to love it. Well, in my mind, the best workflow, the best user experience we can design for a provider is actually no user interface. It's the one they're already using. And so I actually went to one of our customer sites a couple of weeks ago, went to their primary care practices to sit with their physicians while they were, going about their day, seeing their patients, and see how things were going with the deployment of this risk adjustment tool. And I would, ask them. I met with about 10 different providers at 3 clinics. Said, how are things going with your notable risk adjustment tool? And they looked at me really funny, like, what are you talking about? And turns out they had no idea that they were using our software, which normally might be a bad thing. In my case, was the greatest compliment they could have ever paid us, because it meant we had embedded it so seamlessly in their native workflow in the EHR that they had no idea they were using it. They thought it was just part of the EHR. And so I do think having that design, thinking background, understanding exactly what your users are trying to accomplish, what systems they're working, because you're never starting with a blank sheet of paper in enterprise software, in healthcare software. People are already using a bunch of different things. They've already got workflows. So you have to design around the system that they're working in and the systems they're using, and not from a blank sheet of paper.
Yeah, it's this is a lesson I think I learned first when reading Don Norman's book, The Design of Everyday Things, and just a bunch of pictures of doors that were difficult to use. And my translation of his brilliant work was, if a door needs instructions, it's not a very good door. If I don't know if I have to pull or push, if I see a pull or push sign, that's a failure in design of that door, in my opinion. And similarly, if the best designs are workflow, or at least for workflow perspective, is when you don't have to tell anyone anything. They figure that out.
It's there. That's right.
They're just doing it. They don't realize that they're popping in and out of different software, and that's exactly how it is supposed to be. One of the things I like to say when I was on the working for the hospital side was, whenever I hear people say, well, we're going to need to train the doctors, I translate that into, well, our software is not well designed, or at least there's some aspect of design that's, it should just work. The doctor should just see it. Again, this is a goal that's never easily achievable, but should just kind of, well, of course. What else would I have
How much
done?
training did you need for Gmail?
Exactly. And what we want is the ATM experience, where I can figure out an ATM anywhere. But Medicine's a little bit more complicated than that. Let me pivot a little bit to this thing, and I'm not sure if you're aware of this. This might be awkward. Artificial intelligence, AI. Have you heard of this?
No, you're gonna have to walk me through that.
It's Brainiac computers. That's the way I would explain it. How are you? And so I think you are. I think you're joking with me. I think you are aware of AI. Aaron, let's pivot a little bit and talk about AI. I think you had mentioned that Notable wasn't a big user of AI, or you really didn't leverage a lot of AI until the last 2 or 3 or 4 years. Tell us that story of how kind of Notable started and where you're at now.
Yeah. Well, so our co-founders came out of the financial services industry, actually, and they had built a product that helped automate all of the back-end work for mortgage application. So actually, if you think about what's happening last time you applied for a mortgage, you filled out a bunch of paperwork that then someone had to package together into an application and make it digital and make it look to the user like there was a digital workflow going through the different steps of the mortgage process. Well, contrast that or compare that to what happens during the patient access journey, right? What happens with a referral and a prior authorization? It is a bunch of paperwork that is on paper forms, fax documents that we as health systems have to turn into digital data and help the patient see their progress through the system as they go from referral to authorization to schedule to intake to appointment. So our co-founders kind of came together in 2017 around this concept that there was too much administrative burden in healthcare, that costs were continuing to spiral, that the experience was getting worse, and that there was an opportunity to similarly drive efficiencies within healthcare that they had done in financial services, and that we could move from just digitizing things to actually automating them and personalizing the experience for the users. Now, actually, they started on physician documentation. So we're all very familiar now in 2024 with ambient listening solutions. It was a little bit of a newer concept in 2017. And so they actually did start building, deploying, and seeing progress with ambient listening. Realized at the time that the technology was not quite there yet to really deploy it at scale, and that all the things we're talking about around deploying things into physician workflows, it's very hard to do, and every physician wants their own individualized note template. And so a couple of years in, they decided to pivot towards administrative workflows, and so that's where we've actually been focused now over the last 5+ years, is on referrals, prior authorizations, the appointment pre-registration and intake process, on all of the workflows that are so time consuming and labor intensive for value-based care, the chart reviews, the chart scrubbing, the outreach, the care management workflows. And so the company's been completely focused there over the past 5 years. And to your question about AI, we've been using AI in our products since the beginning. However, building AI, one algorithm at a time for each specific workflow, of course, is labor intensive, slow. And what's happened over the last 2 years is that our ability to build, deploy, test, configure, and scale things has just accelerated dramatically. So, as in the past, where it might have taken us several months to build a algorithm for identifying, doing a chart scrub for a care gap, let's say breast cancer screening or diabetic eye exam. Let's go find in the chart through all of the unstructured and unstructured data whether that whether a patient has had that done or whether they need it. Might have taken us months to build and test and configure that algorithm. We're able to do it so much faster now, and so the speed at which we're able to tackle different use cases is just accelerating in a very exciting way the past couple of years as AI is getting better.
And it seems like you're following where a lot of folks are going, which is, hey, it's complicated and maybe dangerous to be working on diagnosis, meaning, hey, let's figure out how to leverage AI so that it can figure out that the patient's got sepsis before they actually have code. And that's difficult to do, and it can backfire on you if it alerts too frequently. Then very quickly, no one wants to pay any attention to it, and then it becomes actually potentially harmful. As opposed to, hey, there's a lot of friction and unnecessary stress, and the friction is unnecessary in the administrative part. So documentation. You talked about prior authorizations and referrals and billing and that sort of stuff that no physician or nurse wants really to have anything to do with. We do it because we have to do it, but it doesn't really help patients. And so that seems like a great place to start with an AI. Anything that can kind of decrease the number of questions a doctor gets about, hey, it looks like the patient has this thing. Well, can I tell the insurance company that they do, right? If that can be automated, if that process can be automated, that lets me focus more on the patient and less on paperwork.
Yeah, 100%. I think I'm not going to remember the exact quote from Eric Topol's last book, but he wrote something to the effect of, "We don't need AI to cure cancer. We really need, or the greatest opportunity afforded by AI is the opportunity to restore the time-honored trust between doctor and patient, the relationship between doctor and patient." I think you said it best. Like, what gets in the way today? My biggest challenge when I go to clinic isn't what's the diagnosis. My biggest challenge is the fact that before every visit, I have to spend 20 minutes reviewing the chart and summarizing, identifying what's happened since the last visit and making sure I'm up to speed. My biggest challenge is after the visit, dealing with the billing, the coding, every prior auth. I prescribe a lot of GLP-1s and I prescribe a lot of insulin pumps. Every single one of those is prior authorization nightmare over and over. It's the referral that I'm, trying to send the patient to cardiology or to orthopedics, and we've got to deal with getting that referral through and another prior authorization. So those are the things that stack up and drive practicing physicians crazy and get in the way of patients getting the care they need. And so, yeah, I think there's a great opportunity to relieve the burden of those tasks and allow, again, this idea of doctors and patients being on the same team. Well, if we can get AI to do the prior auth for us, if we can get AI to be the best intern or medical student summarizing the chart for me before I walk into the room, so that all I need to be focused on when I'm in the room with the patient is their problem, their situation, and talking to them, that's a transformed experience. And so, okay, maybe someday AI will make sure I'm not making a mistake in the diagnosis. But, as any good informaticist, I live my life in 2x2s. So the 2x2 I think of here is like risk versus impact. So what are the things that are super high impact and potentially lower risk? And let's go after those first before we go after things that are really high risk. I think the other piece that, another sort of like informatics rule of thumb and like mistakes I've made time after time in my career, so learning the hard way, is there's an impulse in healthcare to spend all of our focus on the algorithm. And we hear this now all the time as we talk about AI. Let's validate the algorithm. What, is this algorithm safe? Is this algorithm effective? The algorithm is not the product. The product is the workflow in which you're using the algorithm. And so I think that's where, there was a great piece that I think Chris Longhurst and team from UCSD wrote about this sometime in the last year. The reason we've seen hundreds of papers written about successful sepsis algorithms and then very little actually translated into practice is the way in which that story unfolded is all of these research labs built an algorithm, and then they said, how do we deploy this algorithm into clinical care? And they didn't spend time understanding, it goes back to what we were talking about before. They didn't spend time understanding the workflow that they were trying to impact. They just wanted to, put the algorithm into care and see, no surprise, like nothing happened. And so it's actually much more valuable to understand the entire workflow and to ask the question of, what change am I trying to make? And then you can actually just put an algorithm into that workflow to try to influence the change. We saw this at UCSF years ago. My colleague Sarah Murray and her team at UCSF wrote a great paper about no-show prediction. So early on, deployed Epic's standard no-show prediction algorithm. Lo and behold, no change in outcomes or care. And then went back and had to think about, actually, what are we trying to achieve with a no-show prediction algorithm? You're not actually trying to predict a no-show. You're trying to predict which patients need a ride to clinic, which patients might need an appointment, in the morning or the afternoon, which patients have other social needs that need to be met. Those are actually the questions that you need to build algorithms to answer, because those are the actions you're trying to take. And so I think it's a fallacy or a common mistake to sort of build AI in a bubble or in a vacuum or just an algorithm and then go try to deploy it. You've got to start from the workflow, from understanding the problem, and then you can build the algorithm to answer the right question and solve the right thing.
Yeah, it's everything often works perfectly except for the human part. And if we could just get the humans out of the picture, both from the patient and the clinician side, I think it would just work so much better. But apparently that's complicated because I guess you need humans there.
Yeah.
So yeah, I guess we're stuck trying to figure out how to make the technology work. Well, Aaron, this has been a pleasure. I really, we learned a lot and appreciate your time. I always like to ask the last question about something that is so wonderfully designed that it brings you, joy and happiness whenever you use it. We've clearly determined that sometimes that's not the electronic health record. Is there something that you want to tell us about that's it's well designed and leaves you thinking that's really cool every time you interact with it?
Yeah, I love this question. I'm going to go with my AirPods. So they are so easy to use. You carry them around in your pocket. They fit easily in your pocket. You pop them out, you put them in your ears, and all of a sudden you can, connect to the audio of a phone call, listen to a podcast. They connect to my Apple TV so I can watch TV at night without bothering my family. I think the way in which they connect you to your computing device and computing experience is very low friction, very user friendly, and very powerful. If only they could fix Siri, and which they're supposed to have done now. But you can imagine a world where instead of Siri, it's actually ChatGPT or something that works better. And then you've got this powerful computer that you can talk to and use all the time. So I like how simple and unobtrusive they are.
Yeah, that's great. They do two things. One is they work, right? And two is they connect pretty easily if you're within that Apple ecosystem. So yeah, that's awesome. Well, I'm sure that some of the engineers in Cupertino will appreciate the tip of the hat to the AirPod team. Well, thank you again. This has been great. We appreciated having you here and look forward to all the cool stuff that you're going to do in the future.
Thanks, Craig. Always fun to chat with you.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Aaron, follow him on LinkedIn at linkedin.com/Aaron-Neinstein. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.